And welcome to the Talk Eye to Eye Doc channel on YouTube. My name is Dr. Daniel Bustos. I am an ophthalmologist, and it is my hope and desire that you and I talking together will create a wealth of knowledge for you about your eyes and how you can take that to talk to your eye doctor and understand what's going on in your life. Let me give you a little introduction to me. I love what I do. If I couldn't do ophthalmology, I'd probably leave medicine, but I love what I do. I'm an ophthalmologist, as I said, and that is a medical doctor. So I went to medical school just like your regular doctor did and specialized in the medical and surgical diseases of the eye. So now I am a eye doctor, but I am a surgeon. I'm not an eyeglasses doctor. I don't do contacts. I operate and do a lot of cataract surgery, but also treat things like glaucoma and macular degeneration and dry eye. And so I'm the doctor your optometrist sends you to when they have an issue they can't solve, usually surgically. I did my undergraduate education at Brigham Young University in Provo, Utah. I did a graduate degree, a master's degree in anatomy at the University of Texas Health Center of San Antonio. Also did my internship there. Actually did medical school there. Then I did internship there. And for my residency in ophthalmology, I did that at Vanderbilt University Medical Center in Nashville, Tennessee, which brings me to where I am. I actually practice right now in Murfreesboro, Tennessee, which is a kind of a suburb city of Nashville. I have been here in the Murfreesboro area for about 10 years. In the middle of that 10 years, I went to Oregon, Eugene, Oregon, and spent 6 years out there practicing, but I've been back here for 7. Love what I do and love where I work. Anyway, enough about me. So I would like this channel to be about you, okay? I want this to be as close to a real conversation that you and I might have if you're sitting in front of me in my exam chair, okay? As a physician, I pride myself on being different from some other physicians in that I will sit and listen to you. I may not be good at many things, but I am good, I think, at listening to my patients, not doing anything else, but looking them right in the eye and listening to them and saying, I'm listening, what are your issues? What are your problems? And then even the ones that they're not vocalizing, I'm still pretty good at being able to pull those out a little bit and talk to my patients on a very frank, even level, find out where they're coming from educationally, intellectually, emotionally, and then going to that place where they are, meeting them on their level and explaining to them what's happening with their eyes. The goal of that is that I have a patient who is committed to working with me, is a partner in their care of their eyes with me, trusts me, which is really important. If you don't trust me, I can't take care of you. But then is a happy patient and understands what's going on with them and appreciates the good outcome and why. So anyway, that's what I hope this channel is about, and this is my first video on this channel, so I want to welcome all of you who have taken the time to join me. Thank you, and I hope you will come back for many more videos. This is just the first in our series of educational videos, but I want these to be frank discussions, talks, chats, so please feel free to leave me your comments, suggestions, questions. I will do my very best to answer them all, and here we go. So let's talk first about your eyeball. I think it's real essential that you understand what your eye is, and therefore if you understand what it is and what it does, why it does it, and how it does it, at least on a baseline level, then when you go talk to your ophthalmologist, you'll be able to understand what he's doing, what he or she is saying, why they're saying it, and you'll have a better foundation with which to participate in that care. So your eye is not unlike a camera, not the iPhone cameras we have now, and not even a digital camera, but like the conventional camera with film. So your eye has 2 lenses in it that focus light. It has film in the back of it, like your old-time cameras did, and that film is called the retina. And really, I think to get an accurate idea of what the eye is, you should think of it like a webcam, I suppose. The camera sits on your laptop, and then it's got the cord right behind it that trails off your computer. Well, that cord is your optic nerve, and it connects your eyeball to your brain and tells your brain, interprets what your brain is being exposed to interprets the light that you're seeing into neurological signals your brain understands. So it turns the light into brain waves, and your brain understands what you're seeing, and that's how it works. So this is just a small little cross-sectional model of the eye. So we've got the cornea right here, which is in cross-section. It's kind of hard to see. It's one of the lenses in the eye. Right behind the cornea is the colored part of the eye. That's the iris. Okay. Some people have dark irises, some have light. And then behind the iris is where the lens in your eye, this here that I can take out and show you, is the second of the lenses in your eye, and this is where cataract forms. The orange part of this cross-sectional thing is your retina. It's got blood vessels that feed it, I don't know if you can see that. And then, there goes my lens. And then this is your optic nerve that goes back to your brain. So let's talk about what we get out of your eyes. Okay, when you go to your ophthalmologist, we're going to measure your vision. After we check take your history and talk about why you're here, the first thing we're going to do is check your vision. And the reason we do that is because it is our vital sign. Okay, so you go to your primary care doctor, they're going to measure your blood pressure, your respiratory rate, your heart rate, your oxygen saturation. They do all that because that's how they get a quick and dirty idea of what may be happening with you. If your vital signs are abnormal, then something's obviously wrong with you. Well, if your vision's abnormal, that's how we're going to know, by checking your vision. So we call it visual acuity. And visual acuity is your ability to read the eye chart, essentially. There's a lot that goes into that, but the functional endpoint of your eyes and your vision is to see and read and function. So when we measure your vision, we end up with a number like 20/40 or 20/20, 2100. Well, what does that mean? So let's say that I measure your vision in my office and you're 20/30. Okay, maybe you have some cataracts, who knows? But 20/30 means I can see at 30 feet what you only see at 20 feet. Okay, so it's a comparison, and we think of 20/20 as being normal. So it's a comparison. If you're 2100, I can see at 100 feet what you only see at 20 feet. So the higher the lower number goes, the worse your vision. Generally, we would consider 20/20 vision to be normal, but some people have even better vision, like 20/15 or 20/10. Now, when we measure your vision, we want to know what your vision is in your glasses, in your contacts, in the way that you normally have your vision corrected, because that will give us the true idea of whether there's a problem with your vision or not. If you have blurry vision and you don't have your glasses on and you don't see very well, that doesn't tell us much, because some people's eyes have different shapes and need different glasses to correct it. So with your glasses on, with your contacts in, that's how we want to measure your vision. That's how we get a good idea, baseline, of where we're starting and what kind of issues we may have. Now, most times your ophthalmologist's office will check your vision in the distance. Okay, so before I get there though, let's understand the term focal point or focal zone. As humans, we function in life in 3 different focal zones. Okay, so the first focal zone is here for book reading, so fairly close. Okay, like that. The second focal zone is intermediate. So this is kind of out to here where your arms are, and this is, car gauges, computer monitors, tablets, things like that. Okay, that's intermediate zone, and everything beyond that is distance. Okay, so everything beyond your arm's length generally is distance. So generally, we're concerned with what your distance vision is. It is a good surrogate marker for what your other visions, what your vision in your other focal zones would be. So most often, your ophthalmologist is not going to measure intermediate vision or your near vision unless there's some issue with those that we're dealing with. Then once you need a pair of glasses, your ophthalmologist or optometrist can prescribe those, and in the top of your glasses, you're going to have distance vision correction. So the correction that you need, the lenses you need to make the distance vision clear, sharp, distinguished. Okay, and then if you are about over the age of 45, maybe a little older, in the bottom of the glasses, you're going to have some add. Okay, we call it add. It's basically additional power or additional lens power to allow you to see up close. So there's bifocals, where it's just one big segment, okay, at the bottom of the glasses, where there's trifocals, where there's two segments, one on the top to give you that intermediate range clarity, and one on the bottom to give you up close vision. And then now, as of the last 10 or 15 years at least, there's progressive bifocals, or no line bifocals, where you don't see any line on the glasses, but it gives you a range of clarity up close to be able to see what you need to, depending on how far down your eyes look when you're looking through your glasses. When is blurry vision not concerning? Almost never. But going back to what I talked about before, blurry vision isn't concerning to me until it is blurry when it's corrected. So like I talked about before, everyone's eyes are different shape, okay? Well, generally the same shape, but everyone's eyes have different shapes and curves and things like that. So everyone has a unique prescription. It is this difference, the unique shape of the eye, whether the length and the curvature, that dictates what kind of lens you need to bend the light coming into your eye, okay? To focus it, light coming in your eye, to focus it on the back of the retina where the macula is, okay? So your eye is a focusing unit, okay? Those people whose eyes are relatively spherically shaped, they don't have any need for glasses. So they can get by with nothing unless they're over the age of 45, where they start needing something for up close. But inherently, those people don't have any need for glasses. So they're lucky, okay? Good genes. I don't know whatever you want to call it. The people who have a need for glasses have a less than spherical or a non-spherically shaped eye, and that's the eyeball itself and the very front of the eye, the cornea. So once we find out, by putting your face in that big kind of four-opter thing with all the lenses, once we find out what your true refractive error or your need for glasses, we call it a manifest refraction. Once we find out what that is, then that tells us, okay, with the best glasses I can make you, this is your vision. And we'll measure your vision in those best pair of glasses, those lenses. And let's say you went from 20/30 in your right eye to 20/25. Well, the best glasses we can give you, in other words, the lenses you need to bend the light to get back to your retina, you see 20/25. Well, that's a shade off of normal, shade off of 20/20. So I'm not overly concerned about that. Some people don't get the 20/20. Their best they could do is 20/25 maybe. Now, let's say you're the person that doesn't wear glasses, you complain of blurry vision, you come in and we measure you in that little four-opter, that big old monolithic thing, and after we get done with the lenses and you choose one or two, yes or no, we find out that despite the best lenses we can get to fit your eye, the shape, the dimensions of your eye, despite that, let's say we can't get your vision any better than 20/70. Okay, again, that means I can see at 70 feet what you can only see. I can see at 70 feet what you could only see at 20 feet. Well, then there's an issue. If your best corrected vision, that's what we just call that, the vision you get with the best glasses we can give you, if your best corrected visual acuity is less than 20/30 or 20/25, then I start to think something's wrong, okay? And that's when I start to get concerned, okay? Coincidentally, talking about this refractive error, the measuring your glasses with those lenses, when the technician is asking you to tell her or him what's better, 1 or 2, 3 or 4. They're trying to narrow the scope of the lenses that you're exposed to down to what you subjectively as the patient see things sharp as. So it's a comparison. The whole goal of that is to get you seeing as sharp as we can with the lenses that we have, but the whole goal is to get you so the choices they give you end up being the same. So 1, 2. Oh, I like 2. How about 2 or 3? 3. How about 3 or 4? About the same. Okay, that's an endpoint. We know that lens, that part of that part of the measurement is what we want. So don't go back and forth with those choices. You want to we're looking for you to get to the place where both those lenses are about the same. Okay. Now, let's talk about the dual function of the eye. So the eye takes light in from your environment, okay, and interprets that or sends that light to your retina, which is really an outgrowth of your brain, and the retina changes those signals into neurochemicals that your brain understands what they are and you see, okay? But your eye is the camera, the webcam, and without the computer, okay, without the cord, the optic nerve that takes the information to your brain, the eyeball in and of itself is not going to give you any vision. It requires your visual acuity, your vision requires two things. It requires the whole webcam, the camera itself, okay, and then the cord connecting the camera to the computer. Your optic nerve connects your eyeball to your brain. Without your brain, there's no vision. Without your eyeball, there's no vision. They work together. One takes in the signal, one interprets the signal, okay? So the eyeball is part mechanical, so to speak, in that it focuses light rays, and then it becomes part electrical or neurochemical with the retina, and as it goes back to the brain. So let's start with the front. Okay, your eyeball has two lenses, like I said before. The front lens, which you see right here, is the cornea, and I'll turn it in cross section. You can see right there, it kind of comes out like this. And if you turn yourself in cross section and show somebody, they'll be able to see that dome in front of your eye. And that's if someone pokes you in the eye, it's poking the cornea. Cornea bends light and refracts it, so it comes down to a point inside the retina. The cornea is the most powerful of the two lenses that we have, and the cornea is where you might get a foreign body in there if you're grinding metal or if you're weed whacking without goggles on. If something's in your eye and you have to go to the ophthalmologist, they pull it out. It's usually in the cornea. Coincidentally, the cornea has the densest number of nerve fibers of any tissue in your entire body. I routinely pull out foreign bodies from people's eyes on a regular basis, and when I get the foreign body out and put it on a tissue and show them, they have a very hard time seeing it because it's so small, yet the pain that it produces is so exquisite because there's so many nerve fibers in such a small little point. This tiniest little speck of dust you've experienced brings you to your knees. Anyway, because of that, the cornea heals well, heals quickly too, so it's a good benefit of that. The second part is the iris or the pupil, and that's in this cross-sectional model is a brown eye, a brown iris. And some people have blue, some people have hazel, some people have almost black irises, but that determines your color. The pupil, or the hole in the middle of the iris, which is kind of hard to see with the glare, sorry. Maybe you can see it from the back end. Yeah, the hole in the middle of the iris is your pupil. Now, the iris acts like a diaphragm that controls how much light comes through, and the pupil dilates and constricts in response to how much light comes through. So it acts like the aperture in your camera. So when you need more light in, when it's maybe say it's dark outside and you're not getting enough light in, the pupil will start to expand. And if it's real bright outside, you don't need that much light. There's plenty of light coming in, so it's going to constrict. Okay, that's the primary function of the pupil, is to keep the right amount of light coming in. By the way your pupil responds, what it does, how fast, how symmetrically, that gives us clues as whether the optic nerve is damaged in your eye and whether there's any damage along the pathway back to your brain. When you get your eyes dilated, this is what's being dilated, the pupil, the hole in the middle of the iris. It makes the drops you get makes the pupil big and keeps it big, so your eye doctor can see back to the back of the eye, can see the lens better, can see the retina and the macula and the optic nerve better. When you get your eyes dilated, average time to see that dilation go away is 4 or 6 hours, but depending on how lightly or darkly colored your eye is, on who you are and how you process the drops, it can take anywhere from 2 hours to go away to sometimes people tell me it takes 2 days to go away. Well, not everyone's individual, but generally the average is about 4 to 6 hours. During that time, you're going to expect that up close, you're not going to see anything. You're going to have to put on some glasses to see up close. Even if you never do, you're going to need them while your eyes are dilated. So anything really from about arm's length in, it's going to be kind of blurry when you're dilated. Your distance vision should be relatively unaffected, although people will have some halos around things in their distance vision. Otherwise, your distance vision is relatively unaffected. However, the biggest thing is that the light's going to be really bright. So when you go to your eye doctor's office, bring some sunglasses with you. Hopefully they've got some throwaway sunglasses they can give you. When your eyes are dilated, that's what you're going to experience. Now, let me find my lens that dropped on the floor. Okay, so your lens is the second, or your natural crystalline lens is the second lens in the eye. Okay, I can really ought to super glue it there. When we are born, it is as clear as a window, as air. It's supposed to be, so it can focus all the light that comes in your eye back to your retina. As we get older, as we age, just because of living, not because we get older, the lens starts to become darker, dingier. It takes on more water, it forms more collagen, and as that happens, it turns into a darker lens, and we call that a cataract. Okay, and there's many different kinds of cataracts. There's a nuclear cataract, which is just kind of the age-related cataract that many people have, especially as they get older. There's this cortical kind of cataract where you see these little spokes. Let's see, yeah, little spokes and shards on the outside. There is a mature cataract. When a cataract is kind of left alone to get really dense and dark, it becomes very, very white, and the very little vision light gets through that, so that patient has a very poor vision. Anyway, we'll talk a little more about cataracts and cataract surgery later. But without that lens, it supplies about a third of the focusing power of your eye. Without that lens, you need glasses that thick to be able to see anything. Okay. Also, that lens allows you to focus up close. And how does it do that? It does that by changing shape. Okay, so when we focus up close, the lens changes shape to focus the light rays to a closer extent. Okay, that's called accommodation. When we're young and that lens is gooey and plasticky, we can accommodate a lot. We can provide a lot of focusing power for up close just because our lens changes shape so well. Well, after about the age of 40, 45, 50, that lens starts to stiffen up. Okay, it's nothing you can avoid. It's as unavoidable as, more unavoidable than taxes. If you live to the age of 45, everyone's going to have it. The lens starts to stiffen up. The degree to which it bends and changes shape is less, and so because of that, we need extra focusing power that we're losing because it's stiffening in the form of reading glasses. Okay, and then the older we get, about every 5 years from the age of 45 up to about the age of 65, you're going to need to change the power of that lens up the strength. And after about the age of 65, it levels off. Okay, but that's why we can't see so well up close as we get older. That's a function of your natural crystalline lens, the lens that becomes a cataract. Behind, let's take the lens out. Behind the lens, which is here, is this space, this cavity. And this cavity is filled with jelly called vitreous. And this vitreous jelly, when you're born, is like a Jello jiggler. It's really thick and attached to the retina all the way around it. And then as we get older, that thick Jello jiggler kind of consistency of that vitreous gel starts to kind of break down. It turns into more fibrous bands and water. And as we do that, little chunks of the jelly pull off the retina where it's attached to all the way around. And little chunks of the jelly pull off and they float around the rest of the jelly. That's what we call floaters, what everyone calls floaters. Little dots they see in the vision as they look around. And generally you'll see those more in a high contrast lighting environment, like a white paper, a bright sky, a white wall. Those are floaters. They're from that vitreous jelly. And then behind your vitreous jelly is your retina. That's the film in your camera. That's where the signal turns from light into neurochemical. And then those signals are sent through the optic nerve. This is the cable in your webcam, through the optic nerve to your brain. So the retina has a couple of divisions we're going to talk about. The macula is the very center of the retina, and that gives you your central, clear, colorful, discrete, wonderful, straight ahead vision you use 99% of the day. Okay, that's the macula. Macular degeneration is something that takes the vision away in the macula. It's the wasting away of the macula. That's what macular degeneration is. The rest of the retina is periphery, a peripheral retina, and it supplies night vision, light and dark vision, and also supplies your peripheral vision. Okay. The optic nerve, like we said, the cord to the webcam is obviously important for taking the signal from the retina back to the brain. But when you have a dysfunction of the optic nerve, most commonly we see this as glaucoma. That's when there's too much pressure inside the eye that damages the optic nerve and then leads to an area of peripheral vision loss. You can also have damage of the optic nerve through stroke-like processes, masses in the head that can press on it. There's all sorts of issues that you can have with this, but we'll go into that later. So that's just a quick tour through the eye. When we come back in our next video, I want to walk you through a general eye exam, what you're going to experience, what you're going to see, what you're going to hear, what you can expect. I think it's always a good idea to bring someone with you, a loved one, a friend, taxi driver, whoever, who can help you listen and process what's being told to you, and kind of be your sounding board for things that we tell you that you may not get, because everything we tell you just goes over your head, which is real normal. So do stay tuned for our second video, which will come shortly. In the meantime, give me your comments, give me your questions, and the answers are in the box below. Give me your question, I'll answer it. Any suggestions you have about things that you want me to cover, things you want me to discuss and go over, questions that you've always had that you've never wanted to ask because you didn't want to look stupid. I don't believe in the stupid questions, by the way. Put those in the comment section and I'll answer them. And your suggestions I'll take seriously. But do come back. Please stay tuned for our second video. Also, please subscribe, and that will keep you up to date on what we're talking about. I do also want to get in these videos some issues that we're having with COVID and why it's important and what we can look for as far as symptoms in the eyes and what we can do to protect ourselves. We'll get into that as well. But thank you for listening. Please hit the subscribe button and we'll see you soon.